somebody forgot, I don't know what happened, they don't document it properly. And then the data cannot go to the DHIS so that it can be accounted for. And another thing is about changing of registers. We changed the register from 711 summary to 745. And unfortunately, this training and the orientation of these registers was it was done very partially, and this was support from the national government, but we tried to mentor others, and we managed to people to understand and use the new registers. So even there, in terms of documentation, brought us down. And because of the myths and the misconception, whatever you talk to these women, because they have that insight, so we need to talk to them frequently and take a lot of time. It is about the decline. So somebody knows that you've been told, yo, me, I can't go there. I don't have cervical cancer. Maybe this is a witchcraft, something like that. And the other myths and misconception also bring about people not going for the treatment. And when the screening site is separate from the treatment site, then we get some challenges there. You can screen in this site, then when it is for advanced treatment like lip, and you refer this mother maybe to Coast General or to Portrees, they might decide not to go. But in some special cases, we go ahead and take this woman directly and escort them to the facilities, of which it is not very practicable, because even our human resource is another challenge, because we have acute shortage of human resource all over. So this one also affects. And the waiting time, sometimes when they go to the higher facilities, they have that waiting time. What are we trying to do in Mombasa? We're trying to have that directory and the focal people at these treatment centers. And in all the sub-counties, we have focal person in each of the facility, as all of us are doing cervical cancer screening. So we get into direct contact with the people whom we're referring to, and we make the linkage smooth, but still there are some challenges. Another challenge is about cost. This is treatment is very costing, and when they go, maybe let's say lip done in Coast General, it is very costly. We are trying to encourage these women to register for NHIF. Unfortunately, lip treatment is not covered by NHIF. So we need to go further to the NHIF and see what can be done, so that these women cannot be, if somebody has the NHIF, cannot be denied the services. As we all know that prevention is better than cure, we have seen that we have a very high burden of cervical cancer in terms of death and incidence, and the costing of treatment is very high compared to the costing of prevention or early detection like screening. For the facilities, our public health facilities, they integrate, as we have advocated for this, we integrate cervical cancer into family planning and other health services being offered in our health services, in our health facilities. But sometimes you can hear somebody saying that, oh, we don't have commodity, we don't have this. So when we are aware of what is happening about cervical cancer, how is it very fatal, we need to consider these things, to put these things into consideration, like do allocate for commodities. And it is not that expensive. One person can be screened for only 45, approximately 45 shillings. So if we weigh like a screening cost and the treatment cost, we are far apart. They are extremely apart. So we need to do this at our health facilities. When we get the commodities somewhere else, sometimes we get donation from the National Cancer Control Program, sometimes we get from the partners, but if not, we should make sure that we need to do budgetary allocation for cervical cancer commodities. How can we end cervical cancer? This goes also together with the theme of this year. We need to get information. And when we get information about cervical cancer and the human papillomavirus vaccines and how does it cause cancer, then we have to share this information widely. We get information as healthcare providers. Some of us, they don't have this information. Can we get the information? And after getting the information, can we share to the community, share with the other cadres, share when we go to the community? Anytime we get a chance, there's an opportunity to deliver this information about cervical cancer, let us do so. And this is what we are being encouraged on ending cervical cancer. Then get screened. Screening is not only for the people in the community, but even as healthcare workers, we need to get screened. And this start at the age of 30, and it can be done periodically depending on your status, immunity status. Also, we need to prevent this, encourage and advocate for vaccination of our girls, at least by the age between 9 and 14, at least our girls have received the 2 doses of HPV. What are we supposed to do? We are supposed to spread cervical cancer information widely at any forum, we have said. And the slogan says that we should involve ourselves in the advocacy of cervical cancer. So as Mombasa County, for this cervical cancer month, we have been having planning meetings, we have planned activities, and various activities has been going on for the last 2 weeks. This is the 3rd week. And we have planned for dialogues, we have planned for engagement of religious leaders, your talk shows, this is advocacy, and also doing enriches and outreaches so that we can have so many women coming for cervical cancer. We screen them, detect them early, because detection is 100% preventable. So this is the gallery for what has been going on. We have the inter-religious leaders engagement from different sub-counties, and all the sub-counties had this meeting. Then we also take advantage of the chief brothers. When we have any congregation, we talk to the people who have attended, even the male engagement, the women who are there. At least this information goes widely so that we can prevent and end cervical cancer. We have also gone to the radio talk shows, and this is one of the radio talk shows which was conducted about cervical cancer. Thank you for listening and your attention. Any questions?
Thank you very much, Mona Karama, for this wonderful presentation. We will compile the questions through our host here, and then we can be able to ask by the end of the meeting. Okay, once again, thank you very much for the wonderful presentation that you presented regarding the Thank you. Thank you once again for the wonderful presentation that you presented to us. We are now very well informed. We are now advocating to get screened and also ensure that this vaccination has already been given to all our females that have been screened as well for the HPV vaccine. And also thank you very much for letting us know how well our healthcare providers are actually trained in this cervical cancer screening, and how we are advocating as Mombasa County Department of Health in this cervical cancer awareness week as well. Thank you very much. Our next speaker, I think the questions are coming in as our next speaker is coming, and those are comments. So we'll be compiling the questions. Thank you once again. I will start first by introduced myself, but most people had not joined in, so I'll once again introduce myself. My name is Dr. Ahmed Adam. I head the research unit in Mombasa County Department of Health. And now I will be inviting our second speaker to make the part of her presentation for the next part of this webinar. that is none other than Josephine Toiwa. Josephine Toya is a clinician with a background in reproductive health. She's also a part-time lecturer at KMTC, and she's also our sub-county reproductive health coordinator. She's very much passionate about what she does. So please, Josephine Toiwa, the floor is yours, and we can start the presentation. Josephine, you're still on mute. We can't hear you. Yes. Welcome. Josephine? Josephine?
Yes, can you hear me?
Yes, I can. We can hear you now.
Okay, thank you. So, what I was just saying that today we will just want to have a know-how of how cervical cancer comes about and what happens when we get the infection and how we can go about it, how can we prevent, how do we manage. And I know in the audience we might have some people who don't have a medical background, but I'll try my best so that we can at least help so that they can understand, because it will be a bit of anatomy. Also, we have a caution on some of the photos. If they will be disturbing, I apologize for that, but it is what we have on the ground that is happening around us. So I think to start off, from our introduction, we know that cervical cancer is 100% preventable, because usually this is one of the cancers that we have a known cause. As we've been told in the previous presentation, that it is because of persistent HPV infection. That is why we end up having cervical cancer. So
Josephine, you're on mute.
sorry. You are muting me, please. Somebody is trying to mute me. So what I'm saying is usually a sexually transmitted infection, and it occurs in most of the cases. This is a HPV infection, which occurs in 99% of the cases. But when we have 99% of these cases, it doesn't mean that all of them will turn into cancerous, but only a bit of these women that will progress to have cancerous lesions. That is around 1 to 2% of those women who have had persistent infection of HPV. But most of the cases, they will just shed off. They'll shed off the HPV infection. That is when they have gotten infected with the HPV infection. They usually have that period of time that the body system usually helps them to shed off the HPV virus. So it does not mean that whoever has had any HPV infection will end up having cervical cancer. But for those ones who have had it for a long time, and because of some other cofactors that we are going to look at, that will make them also have persistent infection, that is why they will end up with the cervical cancer. So what are some of the predisposing factors that will make us